So with all of due permission, sir, I'm starting with today's live now. So,
Yeah.
okay. Greetings and a warm welcome to everyone. I'm Shwastika, your assigned moderator from Clirnet, and I'm so excited to have all of you with us today, joining us from across the country. A huge thanks for wonderful doctors whose invaluable supports makes events like this possible. We are so grateful for your time and expertise, and we know your presence will make today's session even more special. So before we dive into the main content, let me share a little more about Clirnet. It is one of India's largest live digital CME platforms where doctors can create, share, and engage with some truly innovative medical content. It's a space designed for learning, connecting, and growing together as a community of medical professionals. And now it is my great privilege and honor to introduce our esteemed speaker for today's session, Dr. Amitav Banerjee, sir. Dr. Banerjee serves as a professor emeritus in Department of Community Medicine at D.Y. Patil Medical College, Pune, India. With a distinguished career spanning several decades, he has made remarkable contributions to the field of public health and community medicine. His extensive experience in medical education, research, and evidence based practice has earned him immense respect among the peers and students alike. He is widely recognized for his deep insights into epidemiology, healthcare systems, and the rational use of diagnostic tools in clinical practice. Today, Sir will be sharing his valuable insights on the very significant topic diagnostic tests, uses, and pitfalls in the era of AI. This session promises to provide a thought provoking perspectives on the evolving role of diagnostic modalities. So, without any much further ado, sir, I would like to hand over the session to you. Kindly proceed, sir. Over to you.
Thank you, Swastika, and greetings to all the participants. So, we'll be discussing today an important emerging field of diagnostic tests, and it is assuming more relevance in the era of AI. As you are aware, AI is poised to enter our hospital services, and there is a big investment in AI. In Andhra Pradesh, the chief minister already announced that AI will be used in many government hospitals in diagnostics. So it is very relevant to discuss the what are the pros and cons and how we have to be cautious. So this would be the scope of a presentation, that what are the limits of diagnostic tests. As most clinicians know, no test is 100% correct 100% of the times. They are false positive, they are false negatives. And we'll go into that. Most tests require interpretation in the clinical context. We have to first see the patients, take the history, examine, and then the test is indicated. If this sequence is followed, we will get more true positives. If this sequence is not followed in a healthy population, we may get more false positives. So that we will see the concern on that. And what are the criteria for evaluating a diagnostic test? As you may be knowing, sensitivity, how well it can pick up from a group of people with the disease from a population, that is called sensitivity. Specificity is how well it can pick up the people who do not have the disease, how well it can exclude. So I'll just stress on the core concepts, and because then positive predictive value is that a patient is in front of you with a positive test. What are his chances or her chances of really having the disease? That is called positive predictive value. That has got clinical relevance. And similarly, negative predictive value. Negative predictive value is what are the probability a person with a negative test really does not have that disease. So that is a negative predictive value that again has got a clinical relevance. And based on these above parameters, we have got the likelihood ratios, and which is measured against a gold standard, as you may be knowing. And this positive predictive value and negative predictive value, they can have wide variations. The same test can have wide variations in different samples. We will see as we go along. And now with the AI coming, how it will affect or use or misuse of the diagnostic test. This is our scope today. So Just briefly recapitulate, actually, these things are best taught on with a chalk and board, but just to give the core understanding, as you know, first you have to make a 2 by 2 tables. Leftmost column are the test results. Then second column is disease present. Third column is disease absent. This disease present or disease absent is determined by a gold standard, against a gold standard. That may be histopathology or the already accepted gold standard, and rightmost is the total, marginal totals. So if a test is positive and the person is positive also by the gold standard, that is known as true positive. And if the test is positive and the disease is absent by gold standard, then that is B, column B, that is false positive. And A plus B are the total tests which have come positive by the new test. Similarly, test negative and the disease present, it becomes false negative. And test negative and disease absent, that is true negative. That is for specificity. And C plus D are total negative with the new test. And sensitivity is the out of the total people who have the disease. That is the second column, A plus C. How well it picks up. The numerator is true positive divided by true positive plus false negative. So more sensitive a test, more cases it picks up. But if you keep on increasing sensitivity, you may start getting some false positive also. It will trade off with the specificity. Then how do you calculate specificity? It is the true negative divided by false positive plus true negative. That is the B plus D. D upon B plus D. So this is actually at the population level when you are going for screening or where, but a clinician is more interested in the clinical relevance. So that those are given by the positive predictive value and the negative predictive value. So if you see the first column, that is true positive. Second column, true positive. That divided by the total people who are positive with the new test, that will be given by the A plus B, the first row, last column. So true positive would be A divided by A plus B. So that will give the positive predictive value. That will give the actual, what is the probability that the patient in front of me has got a positive test. Suppose it comes to 90%. So I can tell the patient that 90% I am certain that this condition is present. And of course, you have to correlate with the clinical conditions. If you do, we will see if you do the test in isolation without any clinical symptoms, this positive predictive value get distorted. It can vary 10 times, 100 times also. And similarly for specificity, that is the true negative divided by total negatives. That true negative is D, column cell D. D divided by C plus D. So that is the giving a negative test, what is the probability the patient does not have a disease? So these are the core concept in a diagnostic test. You should try this available. You can see on the net also, because I may not be able to convey on the screen like this, but you get the idea. Always remember, predictive values are for clinical relevance and sensitivity, specificity are in the sensitivity and specificity does not change with the prevalence of the condition in the population. But positive predictive value and negative predictive value, which has got a clinical relevance, they depend on the prevalence of that condition. Prior probability, that is known as prior probability. And you increase the prior probability by a history taking and clinical examination. The more it points towards that condition, so those type of patients you pick up, they will have more chances of the condition. And then the test will be more useful. So this is the clinical use, gives up what is the probability, as we have already discussed. Negative predictive value, rarely they reach certainty. Very rarely, like we used to have the classical symptoms of rice water stools or Koplik spots in measles or rhizus sardonicus. So these are rare signs. It may be a test or it may be a sign, which were very pathognomic. But nowadays, as you are aware, chronic communicable diseases, other conditions which are which has got multiple risk factors, multiple manifestations. So it's very difficult to have a test which is 100% certain. So predictive values are not stable. This is very important, and this will have, or understanding of this concept will help us know the limits of AI in diagnostic. As it is, the diagnostics with the technology, we have got number of non-invasive tests, and many times they are taken for screening tools. There are packages of annual checkups which are carried out on healthy populations. And in these situations, the chances of false positive increases, as we will see. Sensitivity, specificity are stable, but predictive values are not stable. They depend on prevalence of disease. Patient would like to know the implications of a test results. One has to discuss the inherent uncertainties. And this uncertainties increases in a healthy population. If the test is carried out on an asymptomatic person, the patient may unnecessarily go into anxiety. So predictive value has to be taken in context of the population. And that population should have a similar prevalence as when you screen the patient by a history taking or clinical examination. So the art of medicine is not going to die in spite of people predicting that AI will take over the clinician's role. It cannot take over because it cannot connect the dots. It will do the test in isolation. It will not be able to judge the context, and that may cause lot of false positive, lot of extra investigations, lot of anxiety to healthy persons. So before that, all tests have the limitations because all these tests, I'll just go back to the same side. Just another concept I would like to stress that these normal values are not written somewhere in the Gita or Bible or in the book of nature. There is no, they are derived from healthy populations. Large number of people with asymptomatic with perfect health, values are taken. Maybe any biochemical parameter, maybe serum cholesterol, maybe other parameters. And that, as you know, these most follow a normal distribution. So just to have some decision level, 95% values in the center are taken as the norm, and 2.5% on one side and 2.5% on the other side. Extreme outliers, both sides, they are taken as abnormal reading. But remember, when the tests have been taken like this, norms are here, those 2.5% and on both extremes are also normal people. So what does that mean? That means that in using such test, out of 100 people, you will get 5%, 2.5% on either side. 5% will have either low value or either abnormal high value. But they are maybe normal because they have been derived like that. So if you carry out any test in 100 people who are asymptomatic, people will be having an abnormal test, but they will have no disease and they will be running around in circles. Then they will be worried. They will another test. Sometimes they may undergo uh, interventions. So that is something which, and now AI is going to scale these up because it will be um, people will be self-testing with AI. They say it will go in your bathroom or bathtub, they will be imaging and all that, or in your while you are using your car, you will early detection. So the concern is in a normal population without any symptoms, this 5% will keep on multiplying. 1,000 people, you may have 100 people moving around without 10,000 people, 1,000 people. So lakhs of people will be moving around, and that may mislead the doctor and the patient also. So that is why we cannot put the cart before the horse, which is going to appears to be As it is now also, when patient come, doctors, they first ad advise number of tests before examining the patient. So that can sometimes mislead. First, you have to examine the patient. The art of medicine is not going away. And then you will increase the value of the test by creating a sample of people who are tested, who will have a likelihood ratio will increase, prior probability increase, and the test and the clinical correlation will increase because these tests are derived in isolation. So statistically, 5% of people will be normal with an abnormal test. So these are the limitations of the diagnostic test. And these limitations give rise to the pitfalls of a false positive. And the healthier the population, the more the number of false positive. We'll just see in the next example. So this is the illustrative example. A hypothetical new HIV test, say it has got 100% sensitivity and 99% specificity. It's a hypothetical. Let us say a new test for HIV infection. Now we have got three different population with different prevalence of the HIV infection. And then we will see how the positive predictive value will vary. So this is the first population among the sex clinic, STD clinic. So STD clinic HIV prevalence will be very high, 10%. So if you see test positive, 100%, 100 patients are having test positive and HIV also present. And HIV is absent and test positive 9. So true positive is 100, HIV absent and test positive, that is false positive. So total is 109. And test negative is 0, HIV present 0. So, and true negative is 891, HIV absent, and marginal total negative is 891. So in a population of 1000, these are the results. If you see positive predictive value, if you remember, it is the true positive. That is the 100 HIV present and test positive. True positive divided by total positive. That is the rightmost column, first row, 109. So positive predictive value is given by true positive divided by total positive. So 100 divided by 109 is 91.7%. So when the population has got a high prevalence, that is the STD patients, or you have got history of say discharge, urethral discharge, visiting a commercial sex worker. So then you give the test. So the positive predictive value, positive, the person has tested positive, his certainty is 91%. Now we go to the other population where the prevalence is lower. So this is the general population or general OPD where the STD history is not there. So here there are, say, prevalence is 1% only. So 10 out of 1000, total 1000. So 10 will be HIV present and HIV absent. So test positive, true positive is coming 10 and false positive is 10 and total positive is 20. And similarly test negative, second row, but we are calculating, I'm just giving example of positive predictive value. So here the positive predictive value of the same test goes down 10 upon 20, that becomes 50%. So you see, when you have screened the patients who are having likely to have STD with history, or they are reporting, self-reporting to STD clinics, there it was 91.7% was the positive predictive value. Now you in a general OPD, you do the HIV test, the same test is having performance is 50% only. So from 91.7%, it has come down to 50%. Now you go to another population of blood donors who are already screened by history and other things, risk factors, and then you do that test. So there the prevalence would be very less because you have excluded the patients. Here you have general OPD has come. So while exclusion, the prevalence is 0.1%. Here the test positive is only 1 out of 1000. So true positive is 1 and false positive becomes 10. So here positive predictive value becomes 1 by 11. So the positive predictive value is only 9%. So a person who is sitting in front of you, who has got no likelihood of having an STD because of screening and other things, maybe a general population or population no risk. So though the test is positive, patient is worried. But if you see the context, only 9% chance is there that that person has got HIV. And 90% he is free from 90%, 90.9% he doesn't have HIV. The same test is from 91% to 9%, 10 times the performance varies. It's something like a fast bowler who becomes very slow on Indian pitches. He's very fast on English pitches, Australian pitches. Earlier we used to have test matches and they used to prepare the pitch according to the. So the same test will perform very well where the pitch is, say, high prevalence. Where the pitch is low prevalence, dry pitch, the yield false positive increases. The test is performing very erroneously. And this is the worry of AI when it is used almost like over the counter. Like we have over the counter drugs and the value of the drug disappears because resistance, antibiotic resistance. Similarly, the test will become useless if carried out in the, and it will cause a lot of anxiety and lot of misguide. It will misguide the clinician also. So always clinician remember these tests are not a standalone test, but they are being used nowadays. The corporate packages are given, the insurance packages are giving for this test. So that is something which we have to really know the limitations and pitfalls. And now we'll come to the AI, and I'll give an example which was the America experienced this when they introduced AI for diagnosis of for diagnostic as a prognostic. Diagnostic test and prognostic test also work on the same principles. Prognosis, you have a test or a prediction, and the gold standard is actual outcome. So the calculations are the same, positive predictive value, negative predictive value to predict an outcome. So in a clinical history and clinical examination, so that is all we have discussed. Where technology advances, again, there is a tendency to test before we see any doctor. So statistically, I have already said that 5% there is a chance of having a, that is, but when you go to a normal, more and more healthier population, this 5% keeps on increasing. You have seen 50%, the test performance goes down. It goes down still lower. Similarly, if any individual undergoes 20 tests, one will come false positive without his having disease, and which is very common nowadays, the number of tests people keep on doing. AI is trained, and then what are the further limitations of AI? AI is trained on secondary data, large number, and they are validated also on that data, which the manufacturers did. I'll give an example of a AI model, which was used in American hospital for sepsis. And where the manufacturers claimed that it gives 80-90% prediction positive predictive value for sepsis. You know, sepsis is a serious condition, so doctors can take better care of those patients in advance. And when the AI models are tested on a fresh group of patients or a different playing field, they may not perform as they are performed under test conditions. So this is an example. This is a just to give a small background. Epic in the 2018, I think 2017, AI model was launched. Epic Sepsis System, EPS or something. Epic system. Epic was the name of the AI model which predicted sepsis, and it promoted it to large number of hospitals in the USA, and it claimed that it will have 80-90% predictive accuracy, and number of hospitals adopted it, and for many years, almost 4 years, it was not validated. Then after 4 years, some University of Michigan, I think, they carried out external validation of the, which was already in use. Hundreds of hospitals in USA, millions of dollars were already invested in this. So this is, of course, this is the new, this slide, what is in the screen is that AP government, Andhra Pradesh government deploys AI tools in government hospital. This was the news just 3-4 days back. to enable faster diagnosis. They are going to use it. So I just wanted to give this example. This is what the background I gave, the American experience of AI in hospital diagnostics. Which so as I said, Epic was promoted, and it was a proprietary sepsis prediction model in hospitalized patients. This was a Epic model, Epic system sold to hospitals. And when they did an external validation by independent researchers and published it as a peer review research, they found what was the manufacturer's claim. It was totally off the mark. The performance was very poor. It was as good or as bad as doctors could predict better than the model predicted. And by that time, and it quietly withdrew that model, and it had made all the profits. And later it came out, it had given incentives. The AI company had given huge incentives to the hospitals to adopt that model. So that's why I want to caution that we are also going in a very fast way adopt. We should also be cautious. We should ask for peer review, and we should test it in our own population, because these may have been trained in the patients in some other country, and our patients may differ. A lot of things vary, as you know. So this was the study. I will just give the main outcome from this study. How accurately does the EPIC sepsis model, ESM, a proprietary sepsis prediction model implemented at hundreds of years, predict the onset of sepsis? This was a peer-reviewed study carried out, published in JAMA. That's a top journal. So findings in this cohort of so large number of patients they did, the researchers, sepsis occurred in 7% of year. The EPIC sepsis model predicted onset with an area under the 0.60, which is substantially worse than the performance reported by its developer. So it missed 63% of the cases of sepsis. That's a high miss. The study suggests that the EPIC sepsis model poorly predicts sepsis. Its widespread adoption, despite poor performance, raises fundamental concerns about sepsis management on a national level. So this has been the USA experience, and it was exposed to be almost a worthless model. So there is a lot of hype when anything comes, but we have to be very cautious. We use AI, we use it judiciously, we use it after the clinical examination in context. So this conclusion of the researchers were this JAMA study. This external validation cohort suggests that the EPIC sepsis model has poor discrimination and calibration in predicting the onset of sepsis. The widespread adoption of the EPIC sepsis model, despite its poor performance, raises fundamental concerns about sepsis management on a national level. So these are the and this, of course, then there was a lot of media on that criticism. Missed patients and swarmed the staff. It created extra work to sort out, and many patients would have suffered from this wrong prediction. As a part of, and then when they promoted the model, they insisted that the same electronic health record platform what they had. So all the package was here, and they used this 80 parameters for vital signs, lab results, comorbidities to create a predictive model, which turned out to be false. And they had access to all the data of the patient, which raises the privacy issues also. These are the concerns. But the main bottom line is that in spite of being making huge profits, this model did not deliver. And so it raised a lot of other concerns also, that conflicts of interest. Epic had published a rigorous so nobody asked, nobody checked that independent check of whether the thing actually worked. So before we adopt anything, we should have only catching what doctors already knew. So it did not give any edge over the clinical judgment. So then there was an intelligence Epic. Financial incentives to hospitals were given. All those, it came out. The reporting revealed that Epic provided financial incentives, reportedly as much as $1 million to hospitals that adopted its predictive algorithm. So there is a very high pressure marketing of these things. So this is, I think, all I have. And the tool whose effectiveness had never been independently verified in a peer-reviewed study, the financial relationship between vendor and customer. So all these things are now the dynamics of high-pressure marketing and conflicts of interest. The epic sepsis is a case study. What happens when a predictive tool is deployed at scale without independent scrutiny? So they did not share the data. They did not share the. It almost like a black box. The AI is promoted, and doctors may not be very conversant. So this is the conclusion and take-home message. Diagnostic tests, which includes prognostic tests, should be interpreted in context of clinical examination and history taking. The positive predictive value is meaningful if this sequence is followed. So that we should not totally discard AI or other technology, but the clinical examination and history taking should precedence. Then these can be of use. Just automated, you don't know what's happening. And AI has the potential to scale up the test, thousands of tests and other tests by month. So we should not be swayed by that, because you should remember that it will increase the false positives as a statistical phenomena, because the norms are created statistically, not by any scriptures. It is a man-made norms which depends on the distribution. And then only the test positivity value is useful. In asymptomatic cases, it can cause, as I discussed, anxiety, unnecessary further investigation, unwarranted intervention. Use of AI in diagnosis should avoid such pitfalls, as automation offers the temptation to mass rollout of diagnostics. Home testing, ear testing. So a lot of all this trend has already started with a potential of large number of false positives. So these are the, yeah, I'll just give just two references. One is a book on epidemiology for clinicians. They should have the understanding. It's available from Oxford University Press. So it is a good handy book to how to use the epidemiology knowledge among samples and population in your clinical practice, patient in front of you. So that is the actual foundation of evidence-based medicine. And this is the study, if you are interested to know about the AI used in American hospitals. This is a study, external validation of widely implemented proprietary sepsis prediction model in hospitalized patients, JAMA Internal Medicine 2002-1. So that's all, I think. I can stop the screen sharing. So if you have some